Good afternoon, everyone, and welcome to today's webinar titled Global Obesity Crisis Integrating Technology, Precision Medicine, and Public Health for Tailored Interventions. I'm Dr. Harshita Shanmugam, clinical researcher and young research counselor at the European Society for Clinical Investigation. I'm delighted to be hosting today's webinar as part of ESCI Academy and the EU-funded PAS GRAS project. It's an honor to have all of you here as we discuss one of the most pressing global health challenges, obesity. In this webinar, we will explore how technology, precision medicine, and public health strategies can come together to develop personalized, effective interventions for obesity prevention and management. So let me introduce Project PAS GRAS, a bold step towards obesity prevention. Obesity is a growing global challenge leading to severe health complications across all age groups. One promising approach to tackling this issue is lifestyle interventions, known for its scientifically proven health benefits. The PAS GRAS project is committed to preventing and reversing obesity by focusing on four key age groups. Those are prepubertal children, adolescents, young adults, and adults. At the heart of PAS GRAS is a personalized risk assessment tool designed to identify obesity risk early and guide targeted interventions. By integrating lifestyle modifications such as Mediterranean diet, PAS GRAS aimed to achieve a 15% reduction in adult obesity and 30% reduction among children and adolescents by 2050. This project is built on four key pillars. Those are developing a personalized risk assessment tool, implementing tailored intervention, empowering individuals and communities, expanding impact across Europe. About ESCI, one of the key partners in the project PAS GRAS, the European Society for Clinical Investigation has been a leader in clinical research since 1967. As a pan-European society, ESCI serves as a bridge between scientific research and clinical practice, fostering collaboration across Europe to advance medical knowledge and improve patient outcomes. Through its role in PAS GRAS, ESCI is committed to promoting evidence-based strategies to prevent obesity and improve metabolic health. It's now my pleasure to introduce our first speaker of the session, Professor Bart van der Schueren, a leading expert in endocrinology and obesity research. Professor Bart is an associate professor of endocrinology at University of Leuven, Belgium, where he leads research and clinical work in obesity and metabolic diseases. He earned his medical degree from the University of Leuven, followed by a PhD in drug development for migraine treatment with a focus on assessing cardiovascular effects of new drug treatments. After completing his specialization in internal medicine and endocrinology, he continued his research at Columbia University in New York. After studying there, upon returning to Belgium, he took charge of the obesity and lipid clinic at the University Hospital in Leuven, contributing significantly to both clinical practice and obesity research. Beyond in his clinical work, Professor Bart has played a key role in regulatory medicine, serving as scientific expert at the European Medicines Agency and as president-elect of the Belgian Association for the Study of Obesity. Today's talk is obesity as a heterogeneous chronic disease. In this session, Professor Bart will explore the complex and multifaceted nature of obesity. So please join me in welcoming Professor Bart. Professor Bart, here is your screen.
Okay, I just want to make sure that everybody can see my screen.
Yep.
Yes?
Yes.
Okay, and everybody can hear me as well, I hope.
Yes, perfect.
Okay, thank you for this kind introduction, Harshita. So I'm Bart van der Schueren from the University of Leuven, indeed. And I'm, first of all, very glad that ESCI invited me to speak here. I'm an adult endocrinologist, so I'm a bit less into the children and adolescents, but fully aware that this is, of course, where any prevention should start. Maybe first a disclaimer. So I am currently working part-time for the European Medicine Agency. And I just want to say that the views expressed in this presentation are my personal views, and they may not be understood or quoted as being made on behalf or reflecting the position of the European Medicine Agency or one of its committees or working parties. On the other hand, I do not have any industry relations, as this function precludes me from interacting with industry. Yeah, so I don't think this needs much introduction. I took the trends for Belgium because this is where I work. This is the Lancet from more or less 1 year ago, in which the latest trends for Belgium between the 90s and 2022 were given. And so currently Belgium has a population of 11 million and 1.1 million women are living with obesity, which is a prevalence of around 21.2%. So that's 1 out of 5. The men with obesity are at 19.8%, so a bit below, but their increase between 1990 and 2022 has been sharper, so they're catching up, so to say. And then in terms of girls with obesity, there we have a prevalence of 5% with no detectable change, so that's kind of seems to be good news. And then there is currently 82,000 boys with obesity, and that prevalence is actually rapidly increasing. So it seems that the boys are more at risk as the girls. One of the major problems when you see this figure, so when you realize that half of the population is overweight, and almost 20% is living with obesity, then the problem, of course, is absolutely obvious. There is a problem of capacity for treating this disease. And so I'm just talking now really about the treatment of people who already have obesity. And there the big problem is that our healthcare systems have long time kind of ignored the existence of this obesity as a disease. I'll get back to that. And so what happens is that people either have a slight overweight or obesity without any complications, the green ones, whereas other people have highly complex form of obesity. I don't think you can see my pointer, but that's the red faces. And the GPs are not well trained, are not always involved. Actually, I'll get back to that, but most people don't consult their GPs with their weight problem. Only 5% of Belgians actually think that their GP, consulting their GP might be a good idea. So the GP is seldom involved, and then they start referring themselves to obesity clinics, which are in hospital. And you can already see the problem occurring. First of all, there is a very long wait in these for these hospitals. And second of all, in the hospital itself, you get a mix of uncomplicated obesity and obesity. So on the one hand, you're under-treating a number of very complex cases of obesity, whereas other cases of obesity that don't really need third-line care or hospital care or obstructing the problem. So there is really a need to recognize obesity as a heterogeneous disease just because capacity of our healthcare system demands that. And here I'm just going into the 5 A's of obesity management. So it's ask, assess, advise, agree, and assist. I won't go into that very deeply, but the important thing here is to see that assess someone that has overweight or is living with obesity. You have to assess the severity, the complications of the disease, to see whether there is a need to initiate treatment and to tailor treatment on the specific case. And that's actually also in the definition. When we look to the WHO definition of overweight and obesity, they are defined as an abnormal or excessive fat accumulation, but that presents a risk to health. So assessing what the consequences is of this excessive fat accumulation is part of the definition of obesity as such. And then, and this is a bit where the problem begins, usually, and I also showed you the figures in Belgium, all the figures are based solely on BMI. And so for a Caucasian population, this is 25 or above for overweight and 30 for obesity. And this is more and more, and we all know this. We had the Lancet Commission, which came out with a paper over the course of January. This is extremely weight and Caucasian centric, but this is also a problem because it leads to an under and over diagnosis of obesity. But I'll get back to that when I talk about the heterogeneity. So this is something that probably you've all heard of. This is the Lancet Commission and its paper, its recent paper that wants to see clinical obesity on the one hand and preclinical obesity on the other hand. So it wants to introduce, if you want, this terminology of clinical obesity, and that's based on anthropometric measures on the one hand. So BMI is an anthropometric measure, but also waist circumference. But it's also oriented at looking at damage and functional impairment, so damage of organs. And here you can see the numerous diagnoses that can lead to actually the diagnosis of clinical obesity. This has been heavily criticized. I would be happy to have a discussion with you about this, because what happens is that you are, of course, waiting until obesity becomes complicated, because when obesity gets his typical complications, before you start actually treating it as a disease, treating it as clinical obesity. But on the other hand, one of the reasons that the authors have brought this definition forward is that they want clinical obesity to be seen as a standalone disease. And so it's all to do with access to care and financial compensation for any kind of treatment, so lifestyle interventions, but also medical and surgical treatment. And this is the idea behind it. So what are they proposing? And it's each time the same thing, and I think we should stop in the obesity world to discuss this, but we use a variety of metrics, and nobody seems to agree on which metrics is the best, because of course we don't often measure fat directly. You could do that, but that becomes, of course, very complicated to do that in an overall population. And so the most practical option is BMI waist circumference. That everybody seems to agree in, but BMI alone is not enough to really completely grasp the disease as such. And so that's why this diagnosis of clinical obesity has been brought forward. Now, one of the things I want to emphasize here, and I'm going to talk about that later, is that it's very nice for experts to talk about, oh, we don't know which metric to use, but we should realize that even BMI, which is a very, very easy metric, is not registered in the majority of patient files in general practice. So we have to start somewhere, and I think we should start by registering BMI if we in medical practice if we want to get anywhere. And then the second thing is that these anthropometric metrics, even if you use a DEXA scan or an MRI, it still doesn't say anything about the severity of the health impact. And that's why we need to also assess everyone who has excess adiposity for this impact on its health. And that can be the physical, but of course also the mental health. And so staging of obesity and viewing obesity not purely as BMI above 30, but as a heterogeneous disease is absolutely fundamental to provide access to care to those who most need it. It provides an insight in the severity of the weight-related complication. It has a stronger relationship with mortality. I'll get to that. It will also enable us to target our treatments at those who are more in need. One of the systems that's often used is the Edmonton obesity system, and I'll try to explain that to you. I'm just showing one reason to use this Edmonton obesity system. So here you see in NHANES, which is a large American cohort, the proportion surviving, so the mortality rates in the different classes of BMI, so overweight, class 1 obesity, 2 and 3. And you see that in terms of survival, BMI is not able to distinguish between the groups. So it's clear that as a diagnostic and certainly as a prognostic, it's not probably the right measure. What the Edmonton staging system proposes is that you look at the functional, mental, and medical domain, and you score from 0 to 4. And 0 means that there is no impact of your excess adiposity on either clinical risk factors, on the mental functioning or the functional functioning of the patient. Whereas 4 means he's at end-stage disease. For example, complications of diabetes presence, cardiovascular disease, secondary prevention, etc. So it stages people between 0 and 4 based on the 3 domains. And so you can, for example, have someone who has huge functional impact. You can stage him at 4, whereas he has little medical impact. Then the AO score will be 4. So it's always the domain with the highest score which corresponds to the EOS stage. And what you see in this NHANES, and that's the left panel, what you see in this NHANES cohort is that the EOS scoring allows you to really differentiate between those who are likely to have an impact on their survival. And so the higher scores are dying more frequently. So it shows that EOS is one way to go. Now, then we're going to have a look at what we're doing. And I'm, of course, looking at my own country. So maybe other countries are doing better, but from my colleagues, I hear they're not. But so what we then went to look for is how are we doing in terms of these stagings? Because this ambition towards better care, how are we doing in Belgium? And so we wanted to assess, on the one hand, the registration of simple anthropometric metrics, so meaning BMI, and prevalences of weight-related complications. And for that, we went into Integro registry, which is a registry of GP patient files. And what we looked at was, on the one hand, a cohort in which we had anthropometric measures, in which we had BMI. And on the other hand, we looked at the cohort without registered BMI, because we realized that 75% of patient files does not have a BMI or a weight or a height. And then we looked at the differences between these two cohorts, and we looked at very simple, so we only looked at very simple complications, comorbidities in terms of staging. We looked at, do we have a record of hypertension? Do we have a record of dyslipidemia, prediabetes, type 2 diabetes, or sleep apnea? And either based on a clinical diagnosis, or either based on treatment for these diseases, or either based on lab measurements. So these are only 5 complications of obesity. So you would expect the physicians to screen for that. And what you see here, first of all, BMI was only registered in 25.6% of files. So only in 1 out of 4 files do we actually find a BMI. I think this is already a stark realization that we have a problem. And what we see in terms of the comorbidities, if you look at people where you actually have a registered BMIs, these are the full bars, they are at way more likelihood of having a complication such as hypertension, dyslipidemia, prediabetes, diabetes, or sleep apnea than those without a registered BMI. So it's what we concluded out of this is, okay, we only start registering BMI apparently in patients that already have complications of their overweight and obesity. So we relatively late start with the registration of BMI. And if you see these patients in GPs that have a registered BMI, they are already multi-complicated. They already have at 1 out of 3 as hypertension, nearly 1 out of 3 dyslipidemia. So it's already high figures of complications of their obesity. This is another way of showing this. So you have the number of complications going from 0 to more than 4, and you clearly see that you have way less complication in those without registered BMI than in those with registered BMIs. Actually, the majority of patients in which we have a registered BMI in the patient file already has one complication. So this is something to think about. So there is, yeah, absolutely a discrepancy between the ambitions and the real world, I think. And when BMI is registered in general practice, already more than 50% of people have one or more weight-related complications. So then we started to say, well, why is nobody staging? Why is EOS also something that most of physicians are not very comfortable with? And one of the reasons is that EOS, of course, has a kind of subjective feel to it. So, for example, someone has sleep apnea. Do you consider that established disease, severe disease, end-stage disease? It all depends. So the cutoffs are not really clear, but especially in the mental field, this is a problem. What if someone has a depression? Does that put him in established disease, so in stage 2? Or so there is a kind of subjectivity that usually physicians don't like working with. And so there have been several attempts to make EOS, so to say, more objective. One of these attempts you can see on the right hand, it's to use cutoffs. And so this they used cutoffs to differentiate 3 stages of EOS based on glucose, blood pressure, lipids, liver, kidney, etc. So that's a way of making the distinction. And I'm sorry that this slide is in Flemish, but on the right-hand side at least. We decided that these cutoffs, because if I go back, these cutoffs, for example, for LDL cholesterol, they're cutoffs that are a bit made out of thin air, if you want. So we decided we don't really want to do cutoffs, but we more want to do the global risk. And we already have scores such as the European Society of Cardiology CV risk scores that we can use and integrate into the EOS system. And we call it the Belgian obesity staging system because we're from Belgium. And so we wanted to see, is this maybe a better way of stratifying patients? And so we looked, and this is the obesity clinic population in my hospital, and we looked at our hospital, the people visiting our hospital. The mean BMI there is 39. And you see below the prevalence of the most frequent complications of obesity. So type 2 diabetes in 15%, with sleep apnea in almost 40%. So these are kind of, and that's normal. It's a hospital setting, so it's kind of already very complicated cases of obesity, which with only 25% being at 0 complications. And the rest of them, so 75% already has complications. And so we looked at, okay, let's now look within EOS and within BOS. So BOS is the upper one, the Belgian. EOS is the lower one. So EOS is the one done based on cutoffs. And let's look at where would they go in terms of stage of their disease. And you can see that the problem is a bit that EOS doesn't differentiate very well in terms of the fact that everybody ends up in the yellow in the stage 2. BOS differentiates a bit better. It already has stage 3 and stage 4 in a higher percentage of people, and then 0 and 1 also in a percentage. And what you can see is that the scoring, instead of using the cutoffs, moves people from stage 2 to stage 3. But also that using the scores, if you only look at cardiovascular disease, will move people to a BOS stage of 0. So more people will be seen as uncomplicated than when you use the cutoffs. And this is also makes sense because a CV score in the end is a more holistic view of your patient. So it's not because someone has a bit of a high cholesterol, but if it's not smoking, etc., he will have a lower score. So in other words, you also bring some people back to the stage 0 and 1, meaning that we think that BOS would also be a better way of not over-medicalizing any form of obesity. Now, we're trying to improve this and to implement this. This is not so easy, but we're currently doing that. And so currently we're validating our BOS score, and we have introduced into this BOS score, into this Belgian obesity staging system, the preclinical and clinical obesity terminology of the Lancet. So what do we say? Well, you can start staging with BOS from on a BMI of 25 or a waist-height ratio above 0.5. And then you stage based on the current, on the things that are proposed there. So on the one hand, you have your glucose homeostasis. On the other hand, cardiovascular risk scores, your functional well-being, your mental well-being, and you can go from BOS 0, which is basically susceptibility for obesity, to preclinical obesity, that's BOS 1, and then clinical early, clinical intermediate, and clinical late. For example, clinical early when someone has developed diabetes. Now, there is still some discussion whether that shouldn't go in clinical intermediate, but I'll skip the details for that. We're currently validating that with a group of experts using the Delphi methods. Now, that's for, first of all, a look at medical practice. Do we stage this? Do we recognize the heterogeneity of obesity in medical practice? I would say we have the conclusion is basically that on the one hand, we are actually staging quite well. We're looking at the comorbidities, at the complications of obesity, but we're not looking at obesity per se. And this is a problem because it means that we're intervening too late. And in terms of the staging, we absolutely need to end the discussion on what is the definition of obesity and get into the fact that we should view it as a heterogeneous disease, but it at least should be staged. Now, another way of going about this, and this is something that I have been doing in the framework of another European project, is the stratification of obesity phenotypes to optimize future therapy. And so there they have looked at a number of cohorts, the Maastricht, Rotterdam study, so a number of European cohorts, and they looked at, okay, what do we expect based on this BMI in terms of cardiovascular risk? And so they used the cluster method with a dimension reduction approach. It's called UMAP. They took biomarkers associated with CV risk, so the usual biomarkers, fasting glucose, lipids, blood pressure, etc. They then did an unsupervised clustering of all the individuals in the different cohorts, and they made an age and smoking status adjusted association between those biomarkers per unit increase in BMI. And so basically what this all means is you look at the BMI of people and you see how they behave in terms of the cardiovascular risk. And what you will see is that most people will end up in a cluster that we call the concordant cluster. And I'll try to show you that here. Here you have females and males. And you see here the concordant cluster in the females. Sorry, I'm not good at, I don't know whether you see me, but this is the concordant cluster. So these people are behaving in terms of cardiovascular risk as you would expect based on their BMI. But all the outliers are behaving differently than the baseline concordant clusters. And so they identified 5 clusters in the females and 4 clusters in the males. And these have either a higher or a lower cardiovascular risk than expected on their BMI. And so you see the different ones. You have the lipid ones, this is the dull, so to say. You have the liver ones, you have the inflammation ones, and you have the hyperglycemic ones. And so these are the different clusters that you find back in the 2 cohorts. And what you see is that in essence, 75% or even 80% of males go into the concordant cluster, but over 20% are in the other clusters. And so by understanding better where someone is positioned, you will fine-tune the definition of obesity that you would purely base on BMI. So that's actually they made the design themselves, and so you see the different clusters there. Now, what you see here, and it's maybe a bit convoluted to explain, but it's actually quite simple. So what you see here is at each the most frequent comorbidities of obesity. So coronary heart disease, stroke, type 2 diabetes, hypertension, liver failure. Type 1 is in there as well. Rheumatoid arthritis is in there as well. And what they looked at is, okay, how frequent is the disease in certain clusters when compared to the baseline cluster. So the dotted line is actually the baseline cluster, whereas you see the mean and the odds ratio and the confidence interval of the discordant people. So in this time, the hyperglycemic, for example, DHG, are way more likely to have coronary heart disease, as we know. The black ones are unadjusted and the red ones are adjusted for treatment. So you see that with treatment, you bring it down, but it's still higher than the baseline concordant cluster. So in a way, this clustering method allows you to see the heterogeneity of obesity. And so that's important because it allows you to focus on those that are at higher risk for having complications of their disease. Yeah, so some obvious one, type 2 diabetes, for example, they're often going to be in the hyperglycemic cluster, which makes perfect sense. Whereas people with rheumatoid arthritis will be, of course, in the inflammatory, in the DIS cluster, because they have inflammation because of their rheumatoid arthritis. Now, you might be saying this is all very nice and good, but can you also show that treating obesity will then move clusters? And this is what is shown here. These are results from the SOS trial. The SOS trial is the bariatric surgery trial in Sweden. It's still the biggest trial that was done in that setting. And what you see here is that indeed people after surgery will move to the concordant cluster. So the blue one is the concordant cluster. So people will move back to the risk that's normally expected from their BMI in a bigger proportion when they have surgery than when they were in the control group. This is, you can also, in using these clusters, you can actually also evaluate the efficacy of a treatment. Now, this is something else I wanted to show. Because it also means that certain subtypes of obesity, so certain people being in a discordant cluster, so to say, may benefit more from a certain treatment than others. And so this is looking as well in the SOS trial. And what you see here is basically that especially women in the discordant inflammatory state cluster, they have more weight loss because success benefit is here weight loss from a bypass than women in the concordant cluster. So meaning that the discordant inflammatory state cluster was reacting better to bariatric surgery. And this we all know, whereas bypass surgery in people that were in the hyperglycemic cluster, so people that had, for example, type 2 diabetes, was less efficacious in terms of weight loss. It's something we know from clinical practice, but it's good to see that this clustering can actually prove this as well. So what do I want you to take away from this lecture? It's first of all, obesity is a heterogeneous disease, and we are well aware of that. So, and we really have to be careful with the development of drugs for obesity, that we're not over-medicalizing obesity. It's really something that I think is important to prevent from happening. Not all people with excess weight should go to hospitals. This is very important. Then the other thing is that anthropometric metrics are a start of diagnosis. They fail to measure the health impact. So somehow we need other tools to stage. In other words, and it's not so difficult to apprehend, the anthropometric metrics, whether it's BMI, whether it's waist circumference, they are all a risk factor, but they don't tell you anything about the personal patient that you have in front of you. But instead of criticizing our anthropometric measures, we should actually be telling, no, you have to take them because we see that they're missing in most of the medical files, as I've shown you in the GP files. And then staging is not yet commonplace, and this is something that we should really emphasize. So I think that when a healthcare provider sees a patient with excess adiposity, they should be forced to stage them. It's the first thing to do to get a better idea of who to treat and who not to treat. And therefore, and I'll go into this if I have a bit more. Yeah, I still have 5 minutes, I think. I'll go
You
into
can
this
go
a bit more detail. So just to explain a bit where the Lancet Commission was coming from. So what you see here is very easy to understand. So it's on the one hand, you have those who, the first patient is overweight, has a BMI of 28.2. He has excess body fat. But he has no signs and symptoms. This would represent someone that purely on BMI would be, because he has excess body fat, he would be underdiagnosed for obesity because he actually has excess body fat, so he has obesity with no complications, but he does have obesity, so purely on BMI, you would have called him overweight. On the other hand, you can have someone of a BMI of 30 with no excess body fat, but a lot of muscle, with no signs and symptoms. That would be an overdiagnosis of obesity. You would, on the basis of BMI, you would call him, you would rank him as obese, but he's not obese. On the other hand, you have those who have excess body fat but have no impact. That's obesity with preserved health, or what we would call preclinical obesity, if you want. There is not yet no complications. And then you have obesity with ongoing illness, or clinical obesity, which is the fourth case. And so just to go a bit further on this, so BMI 23.7, no obesity, and also in the new diagnosis, no obesity. The 28.8 with no excess body fat, so a muscular person with no signs and symptoms, he would be diagnosed in the old diagnosis as overweight, whereas we would call him now no obesity. And then you have the third case, which is someone with 28.8 but has excess body fat, so less muscle. He would be called now preclinical obesity because he has excess body fat, but he has no consequences of that. And then what we would currently call obesity, so BMI above 30, there you have people who have no obesity, that have no excess body fat or no signs and symptoms, that have preclinical obesity when they have no signs of symptoms, but they have excess body fat, and then that have clinical obesity when they also have signs and symptoms. So this is the new framework that the Lancet Commission wants you to work in. I think it's an interest, it has been criticized a lot, but it's an interesting framework. The point is also that it has been put together by experts. But you can feel where they're coming from. What they want to actually show you is, okay, we need to have a consensus on which people we're gonna treat with the newly developed medicines, because we are not, and it should not be our aim, we should not be treating everybody who has a BMI above a certain threshold with GLP-1 agonists. I mean, and this is where they want to get at, but they only medicalize those where it's needed, and make a distinction between those where obesity is a risk factor, preclinical obesity, and those where obesity actually is a disease, clinical obesity, and please allow access to care for those who have clinical obesity, because we know that it's currently not available, but I don't think I have to convince the PAS GRAS people of the fact that we need better access to care. So, and then, yeah, other experts are then saying, well, no, because in the end, this distinction between preclinical and clinical obesity is concerning us, because we feel that we will delay, and this is actually true, early interventions. So if we don't touch, if we act like, oh, the preclinical obesity, we don't touch those patients, then indeed we will have everybody end up in clinical obesity, and so in complicated states of obesity. This should not be our aim, and we should be looking at excess adiposity earlier on. So this is the fear of, for example, the European Association of the Study of Obesity. Now, I just, one other thing that I think is maybe nice and maybe the audience doesn't know. So it's World Obesity Day on the 4th of March. I think everybody knows that. But what I think is, let's stop fighting among experts about what the right anthropometric measure is, and let's put weights in all policies. There is clearly a problem in our societies in terms of the ability of people to manage their weight. And so we should have weight really in all policies, because in the end, excess adiposity usually leads to complications when you wait long enough. And so this is a podcast that also exists in Dutch, but also in English, about obesity, the economical circumstances, etc., that I want to promote to you. And then I want to thank you all. And I just want to maybe add that I'm also the president of the Belgian Association for the Study of Obesity. So if I have enthused you with my talk, you can always go to the website and look at the information that's out there. So that's it from me.
That was really nice, Prof. Thank you very much for an insightful presentation. Of course, BMI is something that we are also looking, as a marker of obesity when we are classifying subjects, BMI, and then anthropometric measurements. Of course, for most of the patients, it does not work. As you said, we have these terms when we use through obese and then false lean. That means a person with the BMI higher and he's obese, but he's with the muscle, but not with the fat, and he's through and he's not metabolically ill. As a person who's lean, but his BMI is very lower, but he's higher in fat and metabolically ill. It's something very nice to have been discussed. That's nice. I think we'll have to make a bit more changes also in our clinical trials in future based on your presentation. Thank you very much, Prof. So I open the floor for discussions. Any questions from the audience? Professor Neilday, have you got something to say?
Thank you very much for your amazing presentation, also because there is a lack in the scientific communities regarding the BMI. We have lack of a recorded BMI in several studies, and this is not good also in the clinical practice. And I'm very happy because you have introduced several important concepts, including the need for a sub-classification of obesity for precision prediction of cardiometabolic diseases, but also the new classification of obesity. I have a question, and I would like to ask you, may we apply the new definition of obesity according to the Lancet Commission also in the in children and adolescents? What could be the future? Because we know that the obese children will be obese adults, no?
I think, Ali, the thing is that in children, it's first of all, a disclaimer, I don't know much about children. I don't have children, and I'm not a pediatrician, so I really don't know much about children. But the thing that is a bit dangerous when you would be using this type of terminology like clinical obesity, and clinical obesity is really meant for adults, by the way, is that you would, of course, you don't expect a child to have type 2 diabetes. You don't expect to see, okay, hypertension you sometimes see, but so it would be really a missed opportunity to wait for them to develop a kind of clinical obesity. I think there we should really go on anthropometric measures, and maybe another, there is other scores, so as the AOS pediatric score that exists, in which you look a lot at functionality of the kid, at the mental impact of the obesity. So I think there also a holistic approach, but let's not wait for them to develop metabolic complications of their obesity, because they're less prone to do so. So I would, in children, I would really go with anthropometric measures and impact on life quality for interventions. And I would also really push for earlier intervention in children, because we know that if you can prevent a kid from struggling with his weight, you can, a kid that struggles with its weight is going to struggle with its weight lifelong. So we should really try to prevent excess adiposity in children.
Thank you very much.
I don't know what there's other
Any
questions.
questions from the audience? No?
It's Friday afternoon now.
Everyone are already in the weekend mode. But still, I have something that is out of my personal interest because I work with lifestyle interventions. So I wanted to ask, what is the best treatment strategies you would think, Prof? Is it pharmacological or combination of pharmacological and lifestyle? What do you think is the best way to prevent obesity, like globally?
Well, to be very honest with you, I think we are moving in very dangerous terrain currently with I'm very happy there is a development in the anti-obesity drugs. There is no doubt they were needed. And also lifestyle is, of course, very difficult to implement for someone who has a BMI at 40, at 35. So I do think you need to understand that there we would need to do a combination of maybe a pharmaceutical or even surgical treatment, but in combination with lifestyle, because you can lose weight in a very unhealthy way and become completely sarcopenic. And so this is the thing. Where I'm a bit skeptical about now is that you can see that the way that the anti-obesity drugs were used, and I don't know, this is not a unique Belgian problem. I know this is a European problem. Immediately you have supply problems. Immediately you have compliance problems. Patients take these drugs only for a duration of 6 weeks or 3 months on average, the max. So whereas it's chronic medication. So the implementation of such effective treatments really requires us to stage the people, but also to have an infrastructure to kind of give them proper lifestyle advice, which is absent in most health systems. So, and we've seen the consequences of anti-obesity drugs being thrown at people without any knowledge of what to do next. So we should really try to frame the anti-obesity drugs in a proper environment. And what's also something that we need to be aware of is that we can then help people with clinical obesity with, for example, pharmaceutical interventions. Probably they will be safer as a surgery. Those surgeons would kill me if you that I tell you so, but I think they probably are safer than surgery. But it makes no sense as a society to, on the one hand, throw your money at big food giants, and I will not call them name. I will not say specific names, but you know whom I mean.
Yeah.
And on the other hand, at big pharma to then live in this obesogenic environment with 1 injection a week, that just doesn't make any sense. So we should.
It's becoming a business.
Yeah,
It's becoming a business now. And the question here, what occurs is making a simple lifestyle changes in our day-to-day life. We could actually reverse our weight loss, and also we are working on fatty liver. So we always see that lifestyle interventions are better.
Fast, yeah.
But now we are actually afraid when this drugs that are coming in the market, like, how long a person has to take those drugs to reverse their obesity or their metabolic conditions. Is it going to be lifelong? And on the other end, it's very expensive. Now also it's not very much available to the general public. And it's become a huge market, and business is what the industries are looking, and they are just advertising, let's say that word. But from my personal opinion, it's like simple lifestyle changes, everyday changes, and a proper nutritional intake. I think it is better, I just wanted to ask you
But
this.
actually, it's not always so easy. Yeah? Like, for example, if you are a mother with 3 children and you're all on your own and you have 2 jobs you need to do, and then someone comes and tells you, yeah, you also have to move for 30 minutes. It's not people. It's not always so simple to, and
It's
I
not
think
easier, yeah.
that in a lot of people, the drugs can be a valuable tool, an additional valuable tool, but that it should always be with lifestyle changes. Because what I'm a bit afraid of as well is that if you have drugs that, because now currently they give 20%, 25% weight loss, but you can lose weight in a very unhealthy way. And especially when they then stop the drugs and they gain weight, they don't gain it in muscle, they gain it in fat. So we're potentially making things worse in terms of body composition.
Yeah. I think we have some questions from the audience. Yeah. So, yes, we have from an anonymous attendee, but apart from obesity due to genetic causes, is obesity always related to psychological causes? How do we distinguish a non-psychopathological obesity from a BED?
Yeah. It's one of those things that, first of all, you have monogenic obesity in which there is a clean link to genes, but even the all-com obesity is genetic. Yeah, so there are clear studies from adoptive children, for example, that clearly show that their weight is closely related to the weight of their biological parents, even if they don't live with their biological parents. So I think in obesity, there is a strong genetic predisposition. And so to say that any form of obesity that's not monogenic is psychological, I think, yeah, that would be overstating it. And then in terms of the psychology, this is something that it's very difficult to know in people who live with obesity. I find it very difficult to know whether psychological consequences are sometimes the consequence or the origin of the problem, or the etiology, or are they actually the consequence of the problem? Because of course, it's not surprising that you develop strange eating patterns when you struggle with weight, when you have a tendency to put up weight. And we all know some people have more difficulty of managing their weight than others. But what I do think that any treatment of someone living with obesity should have a psychological evaluation to see not only is there a cause, is there a cause in the way there, but also is this preventing them from treating themselves correctly, or what are the consequences of the. So there is a psychological side to it, as with any chronic disease. I think there is the psychological side, but to say that if the etiology is not genetic, then it's psychological. That I would say no. Another terminology that I found to be very condescending towards people living with obesity is exogenous obesity. So it was something that was used in my hospital by the interns. So if they would not find high cortisol levels or any other reason for someone to develop obesity, they would say, well, it's an exogenous one. It comes from the environment, so to say. Well, any form of obesity comes from the environment in the end, but it puts the responsibility very strongly with the patient himself, which I think is not a very productive way of going about the problem.
Okay, one last question. Maybe we have another 2 minutes. It's from Nicolina, but it's about children, Prof. I'm sorry. Why isn't there any serious action on children nutrition?
Yeah, but I think there is no serious action around adult nutrition either.
Adult nutrition as well.
I think I honestly, what I think should happen, because in the end, GLP-1, etc., they're all endogenous hormones which are normally elicited by food. I think the next step is to go back to healthier nutrition. So to use this knowledge to go back to healthier nutrition that allows us to manage our weight correctly. So, but definitely, I mean, we need a comprehensive way of looking at the environment, and maybe not only at food, but also at endocrine disruptors, at the way our urban planning is done. We really need to de-obesogenize our environment.
Makes sense. Okay. I think we are really on time. Okay. Any other questions from audience for Professor?
No, now it's my colleague's turn because I'm.
It's Conte's turn. Can you make her as host, Prof, so she can share the screen?
You cannot share your screen? Okay.
You have to make her host.
And how do I do that?
Just click on the option more
Yeah.
or on her. Just click on the 3 dots on her photograph.
Yeah.
And can you
on her herself. Okay.
on her?
Yeah.
Either on my
Can you
face or in the participants list?
Host marker.
Yeah.
Yes.
Okay.
You should be host now.
No.
Nilde is host
Okay.
now.
Now, yeah. Now Professor Bonfrate is host.
Yeah.
Should me should make myself host. Now Nilde will make myself host.
Okay. So, dear colleagues, it is a great pleasure to introduce the second session of the PAS GRAS webinar. Thank you so much for joining it. And I would like to introduce myself. I'm Leonilde Bonfrate, Associate Professor of Internal Medicine at the San Raffaele University in Rome. I'm Counselor of the European Society of Clinical Investigation and Section Editor of the Society Journal. Before introducing the second session, I would like to invite you to enjoy the annual scientific meeting of the European Society of Clinical Investigation. On the website, you will find the registration form, the abstract submission form, and all the detailed information. The deadline for the submission of the abstract is Monday, 3rd March 2025. You have the chance to apply also for the travel grant, so don't miss this opportunity. And now come back to obesity. We have learned that BMI is in itself a predictor of overall mortality, both above and also below the apparent optimum of normal weight. And obesity shortens lifespan and impacts the function of many organ systems. The weight loss is crucial for individuals with obesity due to the link to increased mortality and several health risks, including also type 2 diabetes and cardiovascular diseases, all of which escalate with higher BMI. Obesity is acknowledged as a society issue rather than a personal one. Significant funding has been allocated globally to programs and regulations in an effort to reduce the obesity pandemic. One moment only, because I have to complete the host profile for Professor Caterina Conte. Sorry, Professor Caterina Conte.
You need to make me host.
So, okay.
Just click on her picture, 3 dots, and you will have an option, make her as host. Sopra.
Okay.
Just click on my image. Just put your arrow of your mouse on my image, and then 3 dots will appear. Click on the 3 dots, and you see an option.
That
it should be like make host, probably.
Okay.
Yeah.
It's good.
You made it. Thank you.
Okay. Okay, so at the 75th World Health Assembly in 2022, member states adopted new recommendations for the prevention and management of obesity and endorsed the acceleration plan of the World Health Organization to stop obesity. Despite the overwhelming evidence of both the human and economic imperative to tackle the obesity pandemic, current trends mean that the global target to halt the rise in obesity by 2030 is unlikely to be achieved. And so I would tell you a story. In 1956, at a key conference at Dartmouth College in New Hampshire, John McCarthy officially coined the term artificial intelligence. The term was used to describe the field of study that aimed to create machines that could perform tasks that required human-like intelligence, such as natural language processing, problem solving, and decision-making. Before the term artificial intelligence were coined, researchers in the field used terms like cybernetics and machine learning to describe their work. However, the Dartmouth Conference is widely regarded as the birthplace of artificial intelligence as a distinct field of study and marked the beginning of a new era of research in machine intelligence. A long time has been passed, but we can say that the story of artificial intelligence is not just about technology. It's about humanity's relentless quest to understand itself. So artificial intelligence has a great potential to advance clinical practice and delivery of patient care. And also, digital health technologies offer a range of potential benefit for people, including improved quality, efficiency, and cost effectiveness of care at all stages, from patient assessment to treatment and ongoing monitoring and support. And so we need to know how artificial intelligence may contribute to both an evolution and also revolution in the management of patients with obesity. To answer this question, I'm very pleased to introduce Professor Caterina Conte. She is a full professor of internal medicine at the San Raffaele University in Rome and the head of the Obesity and Obesity-related Cardiometabolic Complications Research Unit in Milan. She's member of the Diabetes and Obesity Working Group for the European Federation of Internal Medicine. She's member of the Training and Education Committee for the European Association for the Study of Diabetes. Professor Conte is a leading expert in the field of obesity and metabolic disorders. She has dedicated her career to understanding the complex mechanisms behind obesity and also the impact on public health. Throughout her impressive career, Professor Conte has contributed significantly to both research and clinical practice, with a particular focus on mechanisms underlying obesity-related metabolic alterations, glucose metabolism and bone health, and also metabolic and bariatric surgery. Her work has been widely recognized in the scientific community, and her research and publications in important and international journals have advanced our understanding of obesity and the global implication. In this session, Professor Caterina Conte will take us through the latest developments, challenges, and potential solutions in using the artificial intelligence for obesity prevention, treatment, and personalized care. Without further words, please join me in welcoming Professor Caterina Conte, and the title of the presentation is Innovative Approaches to Obesity Prevention and Management, the Role of Artificial Intelligence and Digital Health. Welcome to Professor Caterina Conte.
Thank you, Professor Bonfrade, for this flattering introduction. Okay, so today I'm going to talk about innovative approaches to obesity prevention and management. I will focus on management because, as we said, combining lifestyle with other therapeutic strategies for obesity is very important, and I will also touch upon that. So, as we have heard, let me start my pointer here. So as we have heard, obesity is a chronic, progressive, and relapsing disease, and it's a very complex disease. It's a very complex disease, and we also mentioned during the discussion that it is not that simple, especially, you know, for people to follow a healthy lifestyle, because there are several mechanisms that are triggered by calorie restriction and make people feel more hungry and struggle with their weight and to adhere to lifestyle intervention, especially calorie restriction, you know, diet. It is so difficult for people with obesity to follow a diet and to eat less, because multiple mechanisms favor weight regain after successful weight reduction and make it difficult for people to adhere to a healthy lifestyle. And this is why we cannot just tell people eat less, move more. There is some stigma about people with obesity, but it is very important to stress that it is not as simple as just a matter of eating less and moving more, because there are biological mechanisms that make it difficult for people to follow the indications that are provided by healthcare professionals. And this is why the management of obesity should address the different aspects of this disease. And so medications and surgery are very, very helpful and effective in fighting the homeostatic system that makes so hard to maintain weight, because especially, you know, both the new drugs and bariatric surgery counteract those mechanisms that increase hunger and make people eat more during, you know, some time after weight loss. And of course, we also touched upon psychological mechanisms. And so psychological interventions are so important during weight management to help people learn how to manage difficult situations, for example, emotional eating. So this is also very important to address. But lifestyle, as we have said, is the background on which all of these interventions should be implemented. So lifestyle is super important and is also super effective. In fact, we know that lifestyle interventions, there are tons of studies showing that lifestyle interventions are very effective for producing weight loss. For example, this systematic review and meta-analysis of randomized clinical trials examined the effectiveness of different lifestyle interventions on long-term weight loss maintenance. And so these are the results at 1 year, and you know, they were successful in leading to weight loss. But the problem often with lifestyle interventions is that they are very difficult to implement in real life, because in studies, we know from studies that lifestyle interventions, diet and exercise intensive lifestyle modifications are very effective. And we know that we can prevent diabetes. In people with pre-diabetes, we can achieve significant weight loss. But these are very, very, let's say, time-consuming, and they require a huge effort. For example, here in the same meta-analysis, they analyzed the number of interventions per year, the number of meetings of the healthcare professionals who were taking care of participants in these studies, and they saw that the effectiveness of the interventions increased with the number of meetings with the people. So 25 interventions or more per year means at least 2 meetings a month, which means a meeting every other week. And this is not that easy to implement in real life, especially, you know, for the majority of people who are seen within the public healthcare system, which is often overcrowded. And so it is, lifestyle interventions are very, very effective, but somehow difficult to implement because they require follow-up, strict follow-up, intensive follow-up, and constant interaction with the patient, because the greater the interaction, the greater the success. And in fact, we know from several studies that achieving weight loss, a significant weight loss, is totally feasible, absolutely feasible. Weight loss can be achieved, but in the long term, it is so hard to maintain weight. And this is both because of those mechanisms that I touched upon at the beginning of the presentation. So there are several neurobiological mechanisms that make difficult to keep calorie restriction, but also because it is hard to follow up people constantly, at regular intervals for a long term. And so eventually people regain weight. So what does this mean? Shall we prescribe medications or surgery to everybody? These are very, very effective interventions that have an efficacy also even greater in the majority of cases than lifestyle. But they should always, always, always be coupled with lifestyle interventions because, as Bart just mentioned, for example, it could be even dangerous. There could be, well, there is still some debate on this question, this issue, but for sure, in certain categories of people, for example, elderly people or people with very severe obesity who don't move much and have low muscle mass at baseline, or people with comorbid conditions who also have sarcopenia at baseline. So there could be, a loss of fat-free mass, which also includes muscle, both with pharmacological therapies and with bariatric surgery, a significant amount of fat-free mass loss, half of which more or less is muscle. And especially, as also was mentioned, with repeated cycles of weight loss and weight gain with people who discontinue and then go on meds again, you lose fat mass and fat-free mass, but then when you regain weight, in some cases, you can regain more fat mass than fat-free mass, and so this could lead to sarcopenic obesity. And so this is one of the reasons why we need lifestyle interventions, because it is proven that a healthy diet with adequate protein or diet with exercise or both combined can help preserve fat-free mass, for example. So lifestyle interventions are always important. And these are just the benefits on weight loss and weight loss composition. But of course, we know that, for example, exercise has thousands of benefits in terms of health outcomes. So blood pressure, lipid profile, glycemic control. It is very important to grant support to people for following healthy lifestyle. And so digital health interventions are something that could really help in this respect. So what is digital health? According to the WHO, the World Health Organization, digital health interventions is an umbrella term that includes all forms of technology that help healthcare providers and patients in diagnosing, monitoring, and managing various medical conditions, including obesity. So in 2018, the WHO published a classification of digital health interventions, which aimed to distinguish the different modalities and outlined how each of these modalities can address gaps and existing healthcare needs. And so these digital health interventions were broadly classified into 4 categories based on the target users, so clients, in our case, of course, patients, and healthcare providers, resource managers, and data services. So digital health can help in all of these fields and all of these people working in healthcare, in the healthcare setting. The European Union also has a definition for digital health, which is, let's say, more general, and digital care refers to tools and services that use information and communication technologies to improve prevention, diagnosis, treatment, monitoring, and management of health-related issues, and to monitor and manage lifestyle habits that impact health. So within the definition of digital health, there is lifestyle intervention, lifestyle habits, which is really relevant and pertinent to obesity management. And also the FDA has another definition, and it gives us more detail on which are the technologies included in digital health. And for example, it also includes devices, drugs and biologics, and of course, wearable devices, telehealth, telemedicine, and personalized medicine. And the pandemic has boosted the use of digital services. So until a few years ago, we saw that the definition of the WHO dates back to 2018. So until a few years ago, there was, something moving already around digital health, but the pandemic for sure has boosted the use of digital services within health systems, and also it highlighted the need to urgently address obesity, which is also a pandemic, because we know that people with obesity had more severe disease and higher death rates. So thanks to the pandemic, we felt the need to address even more obesity. We already knew, of course, that it's a big issue for the society and the healthcare systems, and the pandemic also gave us, boosted the use of these technologies. So we had to learn how to use it to manage patients from a distance. And digital health in obesity care can be helpful in all stages of care, starting from patient assessment through the intervention and monitoring and ongoing support, which I believe is one of the most important parts. So we are still at the beginning of this new era, where the use of digital health is becoming more and more common in obesity care. So I think it's a very exciting field, and I think it can really, really, really help us provide our patients better care. So let's start talking about telemedicine. Telemedicine is a term that refers to the use of technology by a healthcare provider to deliver clinical services at a distance. So nowadays, when we talk about telemedicine, we often think of video conferencing, but actually telemedicine also encompasses telephone calls, emails, so any way of communicating at a distance with our patients. So not just telephone, but video conferencing, which is becoming increasingly common, probably more common than phone calls. And especially video conferencing offers a similar experience to face-to-face consultations for the patient and clinician. So I think pretty much all of us have tried telemedicine with our patients, and usually patients are satisfied, especially for follow-up visits. I wouldn't recommend telemedicine for a first assessment, of course. So telemedicine is further divided into 4 categories. The first one describes modalities to facilitate consultations between patients, clients here, and healthcare providers. And the modalities, as I said, can include text messages, phone calls, video conferences, so anything that is not in person. The second category involves virtual monitoring of a patient's diagnostic data or health through, we can also have monitoring devices, for example, EKG, or wearables that can send information to an app or something that is available then to the doctor. And then the third category involves modalities that handle, store, and forward diagnostic data to the healthcare professionals. And the fourth one concerns the communication between healthcare workers. For example, there are platforms that can be used to share information about patients and ask for consultations. So there are some available. Sometimes I use one of them. And it is really, really convenient because you can ask a consultation from another specialist, and this makes things much, much easier. So telemedicine, or I'd better say telehealth, which is, a broader term that includes all of these categories, is really useful and can save a lot of time. So what are the advantages of telemedicine? First of all, of course, telehealth allows patients to receive treatments remotely with ease. It is super easy. Almost anybody can use a phone or text messages or video conferencing. And it can provide healthcare to populations that are hard to reach. For example, people who live in remote areas can be reached by healthcare professionals without the need to move and travel for a long distance. And it can also it can also reduce racial and ethnic inequalities, again, because of the ability to reach broader communities. And it makes healthcare accessible to patients with reduced mobility, for example. And it helps patients to save time, and also doctors to save time, of course, because you don't need to travel to see someone. You might want to see, the best doctor for a certain issue. You don't need to move to another city. You can just have a consultation online, sometimes, depending on the problem. And it can also be a way of saving money. So let's see how it works. There are studies that have assessed the efficacy of telehealth in people with obesity. So let's see in our field how it performs. So for example, these retrospective observational studies analyzed real-world data from adults who initiated obesity management medication treatment within Weight Watcher clinic telehealth program. And it was more than 53,000 participants, so a very large population. The mean BMI of these people was 37, and they assessed the changes in body weight over 12 months and the side effects or the follow-up and the medication usage pattern. So we will see here data about retention rates and weight loss. The retention rates were pretty high, so the majority of people stayed in the program, and the weight loss achieved at 12 months was comparable. So mostly they used the GLP-1 receptor agonists in this trial. The weight loss that was achieved was comparable to what we see in clinical trials. So this is very good, because usually in real life, the results often are not as good. So this is a good sign. I mean, it can work. And let's see some other evidence. For example, in this study assessed why and after how long patients tend to discontinue a digital weight loss program. This was run in Australia, and it was an asynchronous program delivered through a mobile application. And people, after consultation with a multidisciplinary team, enter the program with personalized recommendations, and they can reach out to their dietitian periodically, like once a month. And so reasons for discontinuation of the program were mostly related to drug supply, which is, something different from the intervention itself, or the program cost. Cost is always a problem with weight management, with management of obesity, because in many countries, drugs are not reimbursed, and people have to pay out of their pocket for engaging in a weight loss program. But still, the adherence rates were relatively high, as was adherence time. The mean adherence time was 170 days, which is not bad. And this is another meta-analysis that assessed digital health lifestyle interventions for weight loss in people with pre-diabetes, and they overall showed that there was a significant advantage of digital health interventions towards as compared with standard interventions for weight loss. And these are the results of another meta-analysis that assessed hybrid weight management interventions, so mixed, both face-to-face and digital interventions. And so from this data, we know that face-to-face and telehealth, like phone calls or text messages, was the modality, the most common modality. So this is quite used in studies. And email interventions were also used, and mobile apps were also used in combination with face-to-face interventions, which I believe, based on the literature and on my own experience, that is the most effective modality of delivering an obesity management program. And another interesting thing is that face-to-face interventions were delivered as group counseling, which is also very effective. So combining group counseling in person with digital interventions is a very effective modality of engaging patients. And the effect of weight was very positive, and as well they had positive effect on BMI with circumference and also physical activity levels. So positive results. And also AI, artificial intelligence, can be applied to physical activity interventions. And we know this is another scoping review, we know that AI models are effective in predicting and analyzing physical activity outcomes and pattern. So they can predict and analyze how much energy patient burn, how many calories patients burn. And this is very useful also for patients to know, because they are aware of what they're doing, and this increases awareness and engagement in patients, and also classifying physical activity intensity and behaviors. And outcomes in these studies are favorable in favor of AI applications to physical activity, because the systems can effectively modify health behaviors. And furthermore, the studies are, improving the modalities, adopting state-of-the-art deep learning, and apply artificial intelligence technologies for different tasks in physical activity. And so this is another study that enrolled almost 1,000 participants in a digital health program, which also used continuous glucose monitoring and a mobile app. So we have you know, in our hands now several different tools that can help engage patients and increase their awareness. And so they had three groups of people: healthy people, people with pre-diabetes and type 2 diabetes, and weight loss was significant. And this is just a 14 days, you know, the time during which they wore the CGM. This was just a 14 days intervention, and in just 14 days, they had significant weight loss. Time in range, so the time during which their glucose was in the normal range, improved as well. And also they observed changes in the intake of macros, so improvements, changes in the amount of sugar that was significantly reduced from baseline, for example, or a reduction in the consumption of fat. So an increase in the consumption of fiber. So really, a lot of beneficial effects from using these tools. And also, this is another study where participants received sessions through video conferencing for 12 weeks and were instructed to engage in daily activity and self-monitor weight, physical activity, and dietary intake. And they were divided into two groups. So some participants shared their information with the coach who was following them, and in the other group, the coach was blinded to the data entered by the participants. And this study showed that people who shared information with their coach entered more information about physical activity and eating habits in the mobile app. And so they were more engaged, or maybe they were scared, you know, of being judged by their coach, but still, I mean, sharing information, and they were also able to share information with other people to support them. This helped people to enter more information, and they also lost more weight as compared to people who did not share their information with their coach. So AI in obesity research, AI models, and we know this from big reviews of data, are helpful in detecting clinical meaningful patterns, as we will see in the next slide, and can achieve higher prediction and accuracy on statistical approaches for assessing data. And as I already said, this is a continuously evolving field, and state-of-the-art deep learning models are being adopted. For example, in this study, you know, they developed, they used machine learning to predict weight loss at 6 months. It is so hard to know which patients will respond to a weight loss intervention and which will not. And so with these tools, I mean, they're not just useful for following up, monitoring, and delivering interventions, but also for predicting weight loss and health outcomes. And I want to show you, for example, so this is an online platform that can...
ChemSci is a computer vision exercise and assessment platform.
So yeah, this uses computerized vision and artificial intelligence to deliver exercise interventions.
That provides real-time feedback, corrective guidance, and qualitative scoring to users and patients as they exercise at home or at the clinic. Our platform provides real-time feedback and corrective guidance for MSK conditions, physical therapy.
So this is very nice because patients, thanks to computerized vision and artificial intelligence, get immediate feedback. It's like having a personal trainer at your home. And but it's not, everything is not beautiful. I mean, there are also barriers, of course. There may be barriers to digital health, such as insufficient community broadband somewhere, no access to a computer or smart device, low digital literacy, especially for older people. And some people are just unaware of availability of remote health options. So a big part of this is increasing awareness of our initiatives. But there are several benefits. So in obesity care, obesity risk in people who have not obesity, but are at risk of obesity, developing obesity, treatment pathways through data-driven decision-making, providing real-time tailored recommendations for patients, for diet and for exercise. It can help in personalized healthcare, addressing genetic, environmental, and behavioral factors, enhances precision medicine. So this is very, very important because we are moving towards precision medicine, which is going to be the gold standard in a few years. There are challenges. For example, data quality and accuracy should be ensured. Patient privacy is a huge potential issue. And we should, as for the future, we will, but I mean, it's evolving so fast and so quickly and improving and refining so quickly that, research will improve for sure AI scalability and effectiveness. And we need to develop AI tools that enhance patient outcomes. But I think we're really, really, really going towards that direction. And this will help to reduce obesity-related health burdens and improve public health. So in conclusion, digital health presents a promising pathway to tackling obesity at a global scale. And if responsibly developed and integrated, digital health can transform. I really believe digital health can transform obesity management and lead to better health outcomes and more efficient healthcare delivery. And with this, I thank you for your attention, and I'm ready to take questions. Thank you very much.
Thank you very much, Professor Caterina Conte, for your exciting presentation. And we can open the time for the questions. And I would like to thank you also because we have learned that there is an important stigma of people with obesity, and we have to overcome this kind of psychological also condition of a lot of several doctors in the clinical practice. And thank you also for introducing the role of digital health intervention and also the artificial intelligence. And I have one question for you. In your experience, what are the main critical points by using the telemedicine in the obesity field?
So of course, as I said, for a first assessment, I would not use telemedicine because you need to take anthropometric measurements, you need to weigh the patient, you need to perform a physical examination because as we heard, there are so many complications of obesity, and you need to perform a physical examination and talk to the patient, and all the things we do at the first assessment. So first assessments, I would always do it in person, but for follow-up visits, I would totally use, well, of course, not always, but especially for short intervals, if you need to reassess a patient, for example, you have prescribed an obesity management medication and they're experiencing side effects. So instead of having them coming back to the outpatient clinic, you can just have a telemedicine session and discuss with them strategies to improve and mitigate the potential side effects or stuff like that. So for intermediate follow-up appointments, I would totally use telemedicine. I think it's very convenient, and you could also deliver group sessions, like webinars like this one.
Okay. Yeah.
The dietitian, in order to share information about.
Yeah. It's very, very useful. Yeah, could be very, very useful. Yeah. Thank you. Ashita, do you have question for Professor Conte?
That was really a nice presentation, Prof. I really appreciate your presentation. Let's go from the audience and I'll ask the next one. So we have a question from Bruna Moreira. Do you believe AI could be the solution to fill the gaps in our frail and underserved healthcare systems? What would be the top 3 interventions to implement?
I think I don't know if this could fill the gaps, but of course, for me, it could certainly help with several aspects that are now difficult. We know that there is shortage of physicians everywhere, and the number of people with obesity is steadily increasing, and so of course there is going to be a disconnect between the number of physicians available and the number of people who need assistance. So for sure this will help delivering a better care or reaching more people at least. So 3 interventions to implement. It depends really on which level, because at the societal level, we should make sure that everybody has access to broadband and connection, internet connection, of course, because that will help. Of course, well, you can make phone calls, but video conferencing, I think, is the best modality because you can see the person. You have a face-to-face meeting, although virtual, but still. So of course, availability of internet on a global level would be the first priority, and then digital literacy, both for physicians and for patients, because unfortunately not everybody is confident with using computers, or it's becoming simpler and simpler with our mobile phones. It is so easy to make a video call, but still some people have difficulties, especially the elderly, both elderly physicians and elderly patients. So this is true for both categories. And then the third intervention is increasing awareness in general, and digital instruments can also, social media can be a very powerful tool, and it's digital as well, can be a very powerful tool to increase awareness about the nature of obesity as a disease. And so, because people sometimes don't even go to the doctor because they blame themselves. They believe it's their responsibility. Yeah. It's their fault. And this is also because some doctors blame them and, just tell them, well, if you wanted, you could really lose weight. You should just eat less and move more. But no, we really need to share information on why obesity is a disease, and invite people, to seek the help of doctor for managing their weight.
Just to add one more comment with your thing, Prof. When we are speaking about social media, using it as an awareness, now we have number of influencers that are coming in social media. There are some who are really experts certified, who gives the best solutions, to create awareness, let it be for any kind of chronic diseases or lifestyle interventions also. but there are some people who are like, half and half, and they give some, very little or the false information, and there is a group of people like followers who are following that. And this is something that also dangerous thing when we are talking about this digital health, when we are talking about. So this is something, of course, as you said, the elderly physicians or patients, they have a bit of resistance and difficulties when we tell them to use the digital platforms. We also had come across something like that. The COVID pandemic, it was one of the things that we had to speak, and we also came up with an innovative method to analyze, to get information about what is the weight and lifestyle habits and the psychological effect of the pandemic. And that time we had this problem with the elderly subjects, and then we had to make a phone call and collect the data and get things. But of course, after the COVID pandemic, most of the doctors or physician or patients, they are more comfortable using the digital platform than we were before the COVID era, let's say. So I would like to ask the same question that I asked for Professor Bart. What do you think is the best way to prevent the obesity? Like, what is the best strategy you think? Is it lifestyle or combination of lifestyle and pharmacological? What is your opinion to prevent?
I think so lifestyle should be always offered, and so it's really the pillar of obesity management. And then but sometimes, as I said, it is difficult for different reasons, okay, so to implement. So digital health may help in this respect. Drugs can also help, as well as surgery, as well as psychological support. So it's really personal. So it really depends on the patient you are seeing. So the treatment should really be individualized. We now have powerful tools because these new drugs are very powerful. Bariatric surgery is very effective. And also I'm confident that digital health will help also improving the implementation and sustainability of lifestyle interventions. So I think we now have powerful tools, and so we should discuss with the patient, the benefits and of weight loss, and discuss them with them, which is the best strategy. Pharmacological therapy should be taken long term, and not all the people are happy to take a medication all lifelong. Some prefer surgery, some because it's just
takes no time, and then they can get their weight
it's not a
lost.
magic bullet, because I always tell them it's not a magic bullet, because you always have to combine lifestyle, because there is an issue of weight regain. I mean, you can regain weight even after surgery. It's not a magic bullet. It's not. Obesity is a chronic relapsing disease. So far we don't have a permanent solution. Okay, so this needs to be clear for doctors and patients, because as Bart was saying, some people just take medications for a few months, but it's
They
not.
wanted everything to be rapid. Even rapid weight loss is a problem, and they don't understand it has to be rapid. Or after, we have seen in our studies, when we had given like 12 months intervention, we saw steady weight loss in for 6 months, and the 9th month we had a slow increase, and the 12th month it was like boom. When we were going towards the 12th month, we had this COVID in between, so we again saw a steady weight increase in the graph. But when we compared between our subjects and along with the other European population who were not in the intervention, people who were not in the intervention, that means who had no educational background, education about the obesity, weight loss and stuff, they had a very higher increase when we compared to the subjects who were already educated about the weight loss and how to eat right. And this was one of the results that we saw during COVID. But of course, yes, people think it has to be very rapid. It could be one magic pill or one operation, but they don't realize that, it is a slow process and a steady process. It has to be kept for lifelong. Of course, it has to be treated in a different level of approaches. Yes. But when we are talking about AI, we see AI in everything nowadays. It's booming. It's really going to be everywhere there is AI. Of course, there are always merits and demerits when we are looking at technology. What do you think that is going to be advantage and disadvantage of AI, application of AI in healthcare, like monitoring, health monitoring apps for obesity or lifestyle interventions? What could be your opinion?
Because it's not perfect. You need to keep the human in the loop. There is this express. So far, we need to keep the human in the loop. I mean, someone who makes sure that the information is correct, and especially the interpretation makes sense. So I think we cannot rely totally on AI so far, but of course it's a huge help because it helps analyze data very efficiently, and it seems to perform very well. So I think it will improve, but so far we cannot be, we cannot rely 100% on it.
Yeah. At least we can just relax when we are giving diet to subjects, we can see what they are eating in real time. If app provides something that could be advantageous, but as you said, there has to be a human combination with the intelligence. I think that would make sense than just the AI.
At this stage, yeah, we still need the human in the loop. Yeah.
Of course.
I hope also that by using the telemedicine or the artificial intelligence, we can also reduce the health costs, because we have a very, very high health cost for people with obesity. So this is, I think, another perspective that is important for the health system.
Yes, of course. As I said, this is one of the advantages of telemedicine, because it reduces costs. It reduces costs and makes things more efficient. And so it is another important aspect, especially for people with obesity. Also because we know very often people with obesity, have low income, and so it is hard for them to afford to engage, to enroll in a obesity management program. But telemedicine, especially with group sessions, would be very much cost effective. So this could really, really help improve also the economic aspect, financial aspect.
Okay, thank you very much, and thank you all for joining us today. A special thanks to our speakers for their insightful presentations, and to all the people for your valuable time.